Hello everyone, this is Bob Browner with Community Coronavirus Update number 55. Today we'll talk about some good news in the numbers, but some government failures, some confusion about the quarantine options, and a lot on vaccines. So the good news is that our numbers are falling, which is great, but that we're not out of the woods yet. So what changed? As in the article, I think the biggest change, honestly, was public health professionals going directly to the public and saying, "Look, this is serious. You need to take it seriously. Here's what our hospital looks like. Here's what our ICU looks like." And I think that got people's attention when they saw that their hospitals were being overwhelmed and their local doctors and nurses saying, "Look, this is serious. Please do something, folks." And like Dr. Lawler says, yes, they've passed a lot of mask ordinances, but I think for some reason they passed those more mask ordinances is the doctors and nurses going to testify that we needed to do this. And so I think that kind of put together did make a big difference, and I think has helped to reverse our tide in Nebraska. How do our numbers look, and did we have a Thanksgiving surge? I think we had maybe a little bit of a Thanksgiving surge, and that's probably what this little blip is here, although it could be simply a delay in the test, because in many communities that Thursday that was Thanksgiving was also the testing day, and so the test facility didn't get run. But I think it's more than offset by the fact that a lot of people are wearing masks and doing the right thing now. I think the appeal worked, and I also think that we got to the point where most everybody knows somebody who got severely sick and died at this point, including some people I know who were a little bit resistant till they knew somebody who died that was their neighbor or was in the ICU, and now they're taking it more seriously. Across the state, numbers are generally getting better. So if you want to go to the site, healthynebraska.org, you can see these numbers yourself. Um, Unfortunately, though, we did cross yet another threshold of over 300,000 deaths, according to Johns Hopkins, although most public health experts will tell you the real number is actually quite a bit higher than that, probably in the 350 range. Unfortunately, we'll probably will hit 4 to 500,000 by the time we've got our vaccine and get herd immunity the right way. Unfortunately, we're hitting another horrible time frame. We're getting 2 to 3,000 deaths per day in the United States, which is so frustrating because it just didn't have to be that way. Like I said last time, the ultimate judge at the end is the how many people died under your care, and so the functional or dysfunctional of your government, I think, is measured in your overall fatality rates. The U.S. Isn't the worst. We did pass France, unfortunately, and who did it worst? United Kingdom, Spain, and Belgium are worse than us at least. So I guess we're not the worst, but boy, we could have done so much better. If we were Japan, Ireland, Germany, this is how many deaths we'd had if we had their rates. And so why do I use Germany and Japan? Because they're the countries we compete with. They're 80 plus million people. We should be able to. That's who we should compete with. I use Ireland because a lot of us have an Irish background. I have another kid who lives in Ireland, so I like to hear what my kids, one in Ireland and one in Japan, say about it where they are. Same thing happens at the state level. New York got hit worse, so I don't think you can necessarily blame them for doing that bad because they didn't know what was going on at the time. Everybody else had time to prepare, and despite having time to prepare, the Dakotas are probably your poster child of not doing it right. Nebraska, thankfully, doesn't appear to be as bad as that. I hope we don't come anywhere close to catching them up. However, Maine was probably our poster child for doing it right in the United States. They're a rural state, kind of like Nebraska. Have an independent streak and split up their electoral votes like Nebraska. But their public health response was led by an MD, MPH who had a background, and lo and behold, the numbers worked, and they have far fewer dead people than we did. And even within Nebraska, of course, you had Lancaster County versus the rest of Nebraska. Lancaster County was the first to put in its mask ordinance and some other interventions. And so, as much as people want to complain, we got half as many dead people as the rest of the state. So I think our approach works, and the rest wasn't as good because that's the end of the day. And again, like I said last time, it's also interesting to look at it by congressional district and see, obviously. So the main portion of our congressional district is Lincoln, Nebraska, from a population basis, and our deaths are much lower than everybody around us. So that was the better way than definitely way better than up in here. Other confusion, so there was still a little bit of confusion on the CDC recommendations for quarantine. Actually, I went through the CDC site. These are the exact numbers on the site and how effective each of these quarantine options are. Obviously, 14-day is the best. However, these others are pretty good. And within public health, I tell people it's like nothing. A lot of times things aren't perfect. So just like the surgeon's adage, don't let perfect be the enemy of the good. Or sometimes the other saying is it's kind of like horseshoes and hand grenades. You just got to be close enough. And then essentially, when it gets down to it, 80% of people quarantining for 7 to 10 days is better than 50% quarantining for 14 days. It's kind of a numbers game in the end. And so basically look at the numbers and make that decision. It's going to cause some confusion because people are allowed to kind of make this decision themselves, including parents for their own children. Our school nurses are encouraging the 14-day version, though. If you look at the actual numbers, though, I actually think, if you have access to testing, I would go with the 10-day with a test. That wasn't listed on the CDC. They said it was 7-day with a test or 10-day without. I would go 10-day with a test because it's just as good as 14 days. So it saves you four days if you get access to decent testing. I would use that as my go-to as the 10-day with a test for me. But of course, nobody asked me. But that's my opinion. You can use that to hopefully guide your decision. I think testing is available now if you want to get it. So on day 8, get tested, and if it's negative, then I think day 10 would be good. And remember, for stopping a pandemic, spread doesn't have to be 0; it just has to be less than this mathematical equation of 1. And so that's, again, it doesn't have to be perfect. Now, you and as an individual, though, may make your own decision. So if let's say I have a family member who is going through cancer treatment right now, I'm going to take the best option I can, which is one of these. Not going to risk it here. However, if nobody around me is high risk, well, maybe I relax a little bit. So there's always that ability to make some individual decision based on good data, but please use good data, and here it is. Also, some confusion that is frequently out there is your day of exposure is not day 1. Your day of exposure is day 0. So if you're exposed this day, the first day of quarantine is the day after you're exposed. Also, your quarantine is isn't you don't release on day 10, you release on day 11. And so I think people have been off by a day or two, not understanding exposure day is day 0, and then your time you could get out is day 8, 11, or after the 14th day, which actually is 15, depending on which of those you're going to pick. And so this is a nice little graphic from the Nebraska Association of Local Health Departments explaining this a little better. The other thing I want to talk about is governmental failure. And so Ali Khan, the dean of our College of Public Health, was interviewed by Johns Hopkins on Friday last week, talking about essentially what went wrong. And it was unfortunately partly a failure of imagination. It was a failure of communication. And I honestly think part of it's a failure of what I call political appointees in running healthcare and public health. I've never heard of a attorney general who wasn't a lawyer. I've never seen an audit that was done by somebody other than a CPA. But unfortunately, it seems that any political appointee can be put on top of public health, even though they have actually 0 public health background. And I think that's part of the problem, is we're not putting people who are public health experts in charge of public health. So a lot of the confusion wasn't caused by public health. It was caused by the political appointee overruling the public health expert. And that's why the guidance has been confusing, is because it wasn't put out by public health professionals. It was put out by public health appointees. Expertise versus authority. Yes, you may have the authority, but it doesn't necessarily give you the expertise. And people with public health expertise have credentials like this: MD, MPH, MPH, PhD. So part of the problem is, frankly, people releasing guidance who really don't have the qualifications to understand the math behind the guidance. The good news is that our incoming potential CDC director is Rochelle Walensky, who does have the MD, MPH, and had literally just published an article on mathematical equations on vaccine implementation and herd immunity that was an early release through Health Affairs. So there she is, Rochelle Walensky. She has the background. So this is a very, very highly qualified health professional potentially running public health, who will really hit the ground running. So very excited to see that. Public health department core functions. When I was in grad school, these are the 3 core functions of a public health department: develop the right policy that's going to make people healthy, assess it to make sure it works, and assure that it's actually working. And the policy should hopefully be guided by this data. And unfortunately, that's not been what's happening. So for example, what is red anyway? So red, the green, yellow, red stoplight motif was used because it's naturally intuitive. Unfortunately, for it to work, it has to be actually based on data, not just made up. And then unfortunately, the color scheming was often not put out correctly. All the public health websites that are COVID Act Now, globalpandemics.org, Harvard Safra, all of them are using 25 per 100,000 as their threshold for red. Yet people are already saying, well, it's going down, I'll just make it yellow or orange today. That's not based on any public health science. Basically, you should look at this, but not only this, of course. You should never guide just based on one number, of course. So the good news is the trajectory is good. So this infection rate is essentially just saying, hey, it's going down, which you can see that obviously in the graph here. The other thing that gives me a lot of caution is our positive test rate is still very high. That can mean many different things. So this number by itself doesn't mean a lot unless you write it in context. So the fact that this isn't 20 or 30% like it was is reassuring. However, to know that you have good data, this should be probably less than 5 to 10%. So because this is so high, it means this data might be wrong. It could be that people aren't getting tested, so the numbers could be dropping just because people aren't getting tested enough. So that makes us I would say, would be very cautious to overinterpret this until this number also drops. So you want this less than 25, this number less than 5 probably before I would take us out of the red zone. But chances are people won't ask me anyway. So again, policy development, assurance, assessment, insurance. So schools would be another example I'd use. So we work with our local public health department on a policy to make our schools safe. The next step should be to assess and assure that that policy actually works. And my biggest frustration in the CDC is that they've not really done anything to guide K through 12 schools. They put very sketchy stuff out for our policies to put in place, and no, they've done nothing to assess or assure that it actually works. The same thing I'd probably say is true of our state health department. We've gotten no data from them to make sure that K through 12 schools are safe, and we'd have to frankly just do it on our own, which frustrates me, but we did do it on our own. So in Lincoln Public Schools, if you want to, I push this out Friday. It's a public expert explanation of what our numbers show and my best interpretation of those numbers. They've already been had some pushback on that, and this is descriptive. I'm not trying to blame or shame anybody. It just says this is what the data shows. Now, whether that's the right decision or not, the data is out there for you to see. And that's what we did. We want to make sure the data is out there so people don't interpret it in the wrong ways. So previously, like, people thinking 15 minutes, okay, after 14 minutes, I'm good. No. Is 6 feet a magic number? No. That's why you look at the numbers over time to see and use those numbers to keep the data to keep guiding your decision making. So just like the Japanese, they did a great job of looking at both behavior and location. And so what we wanted to do was say, what's the location of spread within Lincoln Public Schools? And here's literally the raw numbers, and the other presentation gives you a more full picture of it. It turned out that after adjustment, our school average spread wasn't much different than the community. It was statistically equivalent, slightly higher, but statistically equivalent. However, that wasn't good enough for us. We wanted to look at every place within the school and make sure that we weren't missing anything. We did see that in elementary school there was higher rates of spread than the rest of the school, which was actually a surprise to me. The next question, though, so that tells you it's a location spread, not necessarily a policy issue, although there could be policies to change. The next question is where in the school. If it was in the classroom, you would see that it's higher in the staff and paras versus admin, and we didn't see that. So what that argues for the fact that it's not just teachers and paras, that's everybody in the school, is that it's non-classroom spread most likely. Now, is that perfect? Of course not. And is that true in every case? Of course not. We did have some cases where we do think there was a mask exempt kid that spread it to a para, for example, but most of it is happening outside of the classroom is essentially the conclusion we have by this. And that gives us something to now focus more on, because that may be the area where we're letting our guard down, and it gives us data to go by, and we can monitor over time, which is great. And lastly, we'll talk about the mRNA vaccine. To me, this is the most exciting thing happened the last couple of weeks. Doctors are literally, ecstatic, celebrating over this. So it's already being given out, and all the doctors are just posting like crazy on social media. So Jenny Beals and Ann Perlman are some hospitalists here at Bryan Health. They're very excited. For Jenny said, hey, that's the best birthday present. For me, that'd be the best Christmas present ever. This is a little hyperbole, but not too far off the truth. Internet, gosh, I don't know about this mRNA vaccine. All the doctors I know, I want this vaccine so bad I'd take it in my eyeball. Well, maybe not that bad, but still, well, first of all, you don't need it. You can get it in a shot in your arm, just like Ann's picture right there. So you don't need it in your eyeball. So thankfully, and we all want this. The other thing is, again, looking at data. So one of the sites I like is this Your Local Epidemiologist. I think Dr. Caitlin Jelena has done a great job of putting all this stuff out there, and she has the MPH and the PhD, so you've got her credibility and statistics right there to see. And here's the notes on what exactly what the Moderna vaccine says, and so you can look at it and verify it yourself. Quit looking at those internet memes. So I keep getting this vaccine misinformation sent to me. What do you think of this? And my response is, well, first, who's writing this, and what are their credentials? And just Google them and see if they actually have any clue what they're talking about. And so frequently it's just some random person, and even if they have an MD, that doesn't mean they know what they're talking about if they don't have a public health background. So just Google them. It takes you 15 to 30 seconds, and you can tell pretty quickly whether this person has a clue what they're talking about. Example I'll use is I Googled Ali Khan, MPH, MD, at our Dean of our College of Public Health, and within seconds, here I know exactly what his background is. Keep in mind there's another Ali Khan, MD, because Ali Khan for Southeast Asia is kind of like John Smith, actually. But pretty quickly you can establish that he was a CDC expert, that he was a former Assistant Surgeon General, he's the Dean of our College of Public Health. You can see his background. Obviously somebody who has the credibility to be saying this stuff. If you Google something, there's hardly anything other than they're at Holistic Harmony Healthcare, probably not the most credible expert out there. So again, look at the raw numbers yourself, and again, the epidemiologist on your local puts it right out there for you to look yourself. You can go to the New England Journal and look at your numbers yourself. So all of this stuff is very publicly verifiable, and I've got links to all these in the notes sections below. The good news is on these vaccines, they've done a good job of studying it in everybody. Part of the problem is in past studies, they only studied white males, which meant it didn't necessarily, it was wasn't necessarily true for females and minorities. And they've broken it down, and they've done a good job of recruiting men and women, multiple ethnicities, multiple age groups, to establish that works not just for some people but everybody. And so they've done a great job. And look at the numbers: over almost 19,000, and this is just for this vaccine, not for the other vaccines. So these vaccines and mRNA, there are over 40,000 people studied already. If there are unusual side effects, you'd see it. You can go look at the numbers yourself. So vaccine questions coming up. Prioritization. So why healthcare and nursing home first? Well, healthcare, one, they got to be able to take care of everybody, so you don't want them sick. Plus, we're going to go first. So we're gonna buy what we're selling. So I think that's going to build a little trust. If he's your doctor or nurse getting it, well, okay, maybe they're a credible expert. I'm going to put my own body on the line. You should be willing to as well. And nursing home, because those are the people mostly dying. So we're going to vaccine those first. We'll see what the side effects and safety are. And yes, there are side effects. It does seem to have, it has a pretty robust immune response. So you may get a slight fever or a headache, or some tiredness is the most common thing. That's not the fact that you got coronavirus. That's your immune system working to make all those antibodies so you don't get the real thing. It is safe in breastfeeding. We don't know for sure in pregnancy in children because we haven't done studies on them yet. Now we'll do some accidental studies, meaning of those 40,000 people, some of them did get pregnant, and then we'll get some by the way. And so we'll find that over time. But right now, pregnancy in children are sort of a question mark. Can a vaccine be required? The answer is yes, it can. And it's actually gone all the way to the Supreme Court. And so you can go to this Johns Hopkins analysis of that. I don't think it will be required, however, although it could be in certain situations. One possible example, for example, if I were Japan, I wouldn't let somebody fly to my country who hadn't been vaccinated yet. So if you want to travel, maybe you want the vaccine just so you can be traveling everywhere. There may be certain jobs where they may not let you be at that job if you don't get vaccinated. Although I doubt that the government will mandate this vaccine because I don't think it'll be necessary. So hopefully this is all helpful to you. It's a little longer today, but boy, there's a lot of information, and I've got links to everything down below if you want to look at it. And again, the usual disclaimer about this being mostly my opinion, although it is backed up by lots of evidence.